Next session, I would like to welcome Dr. Amit Gupta, Executive Director, National RSSDI, Dr. Jayalekshmi R. Kurup, Senior Medical Officer, Cochin Fort Hospital, Dr. Suresh Kumar, Consultant Diabetologist, Diabe Care India, Diabetes Center, Kozhikode, Dr. Balaji Chidambaran from Kumbakonam.
So I request all the chairpersons to join me on the dais. Our next speaker, Dr. Banshi Saboo. As you know, Dr. Banshi Saboo is a global leader in diabetes, and he is currently the chair of IDF Southeast Asia and Secretary of Diabetes India and editor of the RSSDI textbook of diabetes. And he is known for his many initiatives in the field of diabetes. So another important area is diabetic kidney disease, and this is another a missed opportunity which we are missing in our clinics. So over to Dr. Banshi Saboo for his address.
Thank you. So thanks Amit for kind words of introduction. Thank you JPEF for giving me an opportunity. Today I talk Findranol. And what we are doing, actually we are delaying the diagnosis. Most of the patients who are coming to us is not at an earlier stage, or either primary care physician is not diagnosing them by doing their urine albumin-creatinine ratio. Most of the time it is eGFR or just calculating the creatinine value. So what I am going to talk today is which one to add after the RAS blocker. That's very important, whether it's an SGLT2 or Findranol both, because that's always a confusion, and we have the subgroup analysis. Then there are dedicated trial for SGLT2 inhibitor for diabetes kidney disease. And this is, I'm sure we all know about the epidemiology of diabetes. The patient of CKD and type 2 diabetes at increased risk of death from CV related diabetes. I'll be finishing my slides little faster so then we can have discussion, because Dr. Manisha Shai is not there, and this is very important topic where we would like all of you to involve. Oh yes, you are there. Then fine. So then nothing to worry, and then all four chairpersons are there. But somebody told Dr. Manisha Shai is not there, so sorry for that. So patient with CKD and type 2 diabetes are at increased risk of diabetes at CV death. Diabetes and CKD are independent risk factor for all cause mortality and CV mortality. This is what is CKM, a new term which has been introduced, the cardio-kidney metabolic syndrome. A person with no risk factor and a person with severe LV dysfunction with cardio-kidney disease, they are the one with CKM syndrome. It's a chronic kidney disease, is defined not just by the urine albumin-creatinine ratio but decreasing eGFR both. And the prognosis is not just depend on the green color, because you might be seeing only the eGFR. It is the albuminuria is also very important. That's what we will do in G1, G2, G3, G4, G5, G6 with A1, A2 and A3. The overview pathogenic factor is, it's not the metabolic factors or a hemodynamic factor. So normally what we do, a person with diabetes kidney disease, you wanted to treat them intensively with a glucose control and other side with a good and tight blood pressure control. But we are forgetting one pathway, which is inflammation. Inflammation and fibrosis is an important pathway, and this is a real world scenario. CKD is poorly recognized in patient with type 2 diabetes. So even it is stage 5, stage 4 are missed by the primary care physician, and that's very important. The stage that CKD is actually not diagnosed the way it should be diagnosed. Now, urine albumin-creatinine ratio, which is very, very important, when it should be screened every year for all your type 2 diabetic patients. Now you have a point of care testing. This is a very, very important biomarker other than eGFR, which has now been calculated. When you send the patient blood report of creatinine, you will get a calculated eGFR report. But don't forget to do urine albumin-creatinine ratio. It is not just 30 to 300 is important. Now the new data had come, even between 3 to 330 also had also become very important, increasing as a pathology and endothelial dysfunction. So do as early as possible. And we had shown the data that putting these patients on SGLT2 and Findranol both actually decreasing the further and halting the progression of DKD. So the urine albumin-creatinine ratio is very, very important investigation. Don't forget to do it. it in your patient, because many of the time we just send the blood report and not sending the urine and just getting and calculating completely only on basis of CKD is eGFR2. So CKD evaluation is not just on eGFR, also make sure that you are doing A1, A2 and A3. A1 is less than 3 but less than 30. I mean more than 3 and 30 milligram per gram is important urine albumin-creatinine ratio. And that is the earliest biomarker of diabetes kidney disease. Even before anything happens in retina too. I'm sorry. This is some very interesting data that if you are depending only on proteinuria, that is more than 30 milligram, then you are actually diagnosing only 6.2%. But when you are diagnosing between 3 to 30, you are actually diagnosing more than 24.7% of the patient. That much prevalence of microalbuminuria you will find in a patients of diabetes with the duration of more than 1 year. So if you have all your patients whose duration of diabetes more than 1 year, if you will get their UACR, you will be surprised to know that more than 3 milligram you will find in 24.7%. If you are dependent only on more than 300 milligram, 30 milligram, then you will be diagnosing only 6.2. So you are actually under-diagnosing the diabetes kidney disease. And as urine albumin-creatinine ratio starts coming, the cardiovascular mortality starts increasing. This is what somewhere we are missing. If you are calculating only eGFR, many of your patients for years together where they have urine albumin-creatinine ratio, they are not diagnosed with diabetes kidney disease. So UACR is now been a standard of care, not only by the different guidelines, but it has been frequency, confirmation, screening test, all has been done by KDIGO, ADA, ESD, ESC, including our RSSDI guideline too. The progression, as I told you, the hemodynamic and metabolic factors are important, but this factor is completely missed out. We don't do anything for inflammation, and that requires a treatment, and this is now a new modality of treatment which is available to us is a Finrenon, because there is a lot of residual risk. If you just see the residual risk even after putting the patient on RAS blockade or even after putting the patient on SGLT2 inhibitor, still there is a lot of residual risk with the persons with type 2 diabetes for DKD. So they need MR, because there is a MR overactivation in the persons with CKD, and that's an important reason for them to have fibrosis. So start these patients as per the KDIGO guideline. The holistic approach should not be just restricted to up to SGLT2 inhibitor. Give them also the therapy of Finrenon, which is mineralocorticoid receptor agonist. That is what the management. So now the pillar is these three, but now a new pillar, these two new pillars which are going to be added. One is definitely non-steroidal MRA, which had come, including it has got the benefit of heart failure and CVD, and the other is GLP-1 receptor agonist, which is the after flow trial. This had also become a standard of care with the patients with diabetes kidney disease. So now era of 4 pillars. It's not only the one pillar which we used to treat all our patients with DKD with ACE or ARB or with a tight glycemic control, but these 3 are very important pillars to be added, or they are the one which are to be added in a patient. The RAS blockade we do, that's what the foundation of therapy. I don't want to talk more about it. And then we had come the SGLT2 inhibitor. It was originally in a cardiovascular outcome trial. They have done a subgroup analysis to show that there is a relative risk reduction, and further progression can be halted with a 39% relative risk reduction in a dedicated trial of DAPA-CKD, which is nothing to do with a patient with chronic kidney disease with albuminuria. They have done, even they have used the non-diabetic patient also, and benefit was significant. Then there was a AMPA kidney study which was also been produced, and that study had also shown a significant benefit. So then SGLT2 inhibitor had become the part of the therapy. We know about the safety profile. So the people with type 2 diabetic patient, DKD therapies is ARB plus SGLT2 inhibitor. But this important third pillar, which is MRA, this had come because despite maximally tolerated ACE and ARB, these patients are still at higher cardiorenal risk. This elevated aldosterone activity leads to increased mineralocorticoid receptor activation, and this MR activation triggers pro-inflammatory and probiotic pathways for patients with DKD progression. And this is aldosterone escape and MR activation. A next frontier need for non-steroidal MRA. There is always a risk of hyperkalemia, gynecomastia, and limited clinical outcomes. So somebody may say that can I be used on spironolactone and eplerenone? No, because there is no data, and they have the side effects too. The cost is a challenge. We understand this newer is going to be costly, but these are the challenge because we don't have the limited clinical outcome and a risk of hyperkalemia, which is very, very high, and that's what the Findranon is there. And how the pillar is the now standard of care or therapy for using the patients on RAS blockade, SGLT2 inhibitor, and Findranon. I just finished the talk because on Findranon at the ground floor just before some time that it's a non-steroidal. We have a data to support it that in a Fidelio DKD study and Figaro DKD that using Findranon and these clinical trial had shown the benefit. The primary outcome in Fidelio DKD study was composite endpoint time to kidney failure and sustained decrease in eGFR decline or kidney related death. And while Figaro DKD was primarily a cardiovascular outcome time to CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And here you can see that the results of Findranon in reducing kidney failure and disease progression in diabetic kidney disease, that is Fidelio DKD results, to show that risk reduction by 18%. Secondary CV outcome was also favoring all Findranon, whether you go for secondary CV outcome, CV death, non-fatal MI, non-fatal stroke, and non-fatal hospitalization for heart failure. A lower mean urine albumin-creatinine ratio with Findranon plus placebo was maintained throughout the study. Overall summary was showing the risk of progression by 18% and risk of CV morbidity and mortality by 14%. There is a Figaro DKD results which had shown CV risk reduced by 13%, ESKD result is reduced by 36%, UACR changed from baseline to show, you can see from baseline, and those who are already 32% urine albumin-creatinine ratio reduction with Findranon in month 4. And this is, I'm sure, all those who had used in their clinical practice. And if you do urine albumin-creatinine ratio and you add Findranon, you will find within 3 months and 6 months. And I have presented my own data of my clinic for 80 patients last year in ADA to show that within 4 months, actually there is a significant reduction in urine albumin-creatinine ratio, which had shown 13% very statistically significant reduction in risk of CV morbidity and mortality. And same way there is a CKD progression also been decreased with HR of 0.87 to 95% confidence interval 2. Fidelity is actually a pooled analysis of both the trial, and this has been published to show that a trial to show that the patient, the same Fidelio DKD and the Figaro DKD primary outcome, the fidelity is the key outcome is the CV composite, the time to CV death, and 57% kidney composite. So both the trials were combined, and the fidelity paper was published to show that Findranon significantly reduced the risk of CV composite outcome by 14% compared with placebo. So that's what the CV safety and benefit of using it. It also significantly reduced the risk of kidney composite outcome by 23%. It has pre-specified on treatment analysis risk of all cause mortality and CV mortality benefit is also there with the people who are using Findranon. So any drugs which we want to use in diabetes, we have to see that it actually decrease the cardiovascular mortality or cardiovascular benefit is there or not, because it had shown primarily that DKD progression is halted, but here also it shows that the risk of all-cause mortality and CV mortality also is being benefited. Findranon has shown consistent benefit across a spectrum of patients, irrespective of baseline A1C. So even your patient whose sugar is high, A1C is not controlled. Before A1C to control, should I add? Yes. Even the benefit is there. Diabetes duration. As someone who is a shorter duration of diabetes, longer duration of diabetes, irrespective of the person is already on SGLT2 or not on SGLT2. If on SGLT2, add. If not on SGLT2, add both the drugs. And this is what the data to show that it has been duration, elderly people, person already on SGLT2 inhibitor, even those who are already on GLP-1, which had also shown the benefit. So the Findranon at every level, the subgroup analysis had shown, irrespective of anything, you add that and there is a benefit. Last, very important, is a confidence trial, because everybody was looking for that if we add SGLT2 and Findranon combinedly, is there any benefit? And this is is a randomized control trial, confidence trial, where both these molecules has been added together to see the benefit. And what they had shown, that confidence trial had shown Findenon and AMPA reduction in urine albumin-creatinine ratio 29% greater. So if you add alone versus Findenon alone, there is a benefit of adding both together. 32% greater if you add only AMPA. There is a least squares mean ratio of difference in the change from baseline. This is 0.71 with confidence interval of 0.61 to 0.62, 82 with a significant p-value, and 0.68 with a 95% with confidence interval of 0.9 to 0.79 with significant p-value. And these are the different guidelines in last couple of years from 2022 to 2024. You can see that different international guidelines have recommended that this should be the standard of care, and they had put this molecule as a part of important therapy for diabetes kidney disease. In fidelity, CV and kidney benefits of Findenon were consistent irrespective of SGLT2 inhibitor. It had also shown in a subgroup analysis the benefit are more, and concomitant use that you have to use the cardiovascular outcome benefit of both the molecules. But one very important advantage of using both the molecules, that hyperkalemia incidence actually decreases, because Findenon increase the potassium level while SGLT2 inhibitor actually decrease the potassium level. So that CV and kidney benefit both is there. Findenon is approved in India as well as in US FDA approval, and new paradigm that from cardiorenal metabolic risk you have to add the good glycemic control, SGLT2 inhibitor, now GLP-1 also, but don't forget to add the Findenon 2. There are barriers. One of the important barrier is the cost. Cost isn't always a challenge for Indian patient, but it's still how you explain and what's the importance at an early course of the disease if you do, because treating CKD is much more costly than, the therapy of CKD management when they get an end stage or when their creatinine value becomes very high or eGFR goes less than 30, instead of them treating early and delaying that is actually cheaper. Even the cost of therapy may be costly, it look like that. Thank you very much. And I'm little faster, and we thought that we will have discussion. Now we have Dr. Manisha. She is an expert nephrologist. She will be talking, and we can have question answer either at the end or before. And thank you very much once again to JPF. And I invite all of you at our next meeting of National Meeting of Diabetes India, which is in month of Feb from 12th to 15th of February at HICC Hyderabad. Dr. Rakesh Shah is a organizing chairman. Myself is the secretary for Diabetes India, and Amit is a joint secretary for that meeting with SR Arvind as the president. Thank you very much. Sorry.